Good evening. As usual, you've been waiting for your favorite program. That is the University of the West Indies and You. That which takes place every third Thursday of the month. And today, this evening, we have with us something that may be dear to your heart. And I say your heart because it needs the heart to pump a lot of blood into what we're going to be describing, and that concerns you. And he hails from Trinidad. He's a professor at the University of the West Indies, based now at Mona, a medical doctor with a background in biochemistry, which some of you may know is my field. But we are going to be talking tonight about obesity. I am seeing many of you. What happened? Have you put on your tracksuit and get ready to start exercising? Well, you should have been doing that many times before you put on that excess bit of, of weight, let's put it that way. And it's always said that whatever you eat reflects you. So we will look at your nutrition. We will also look at exercise and all the implication of obesity. He is here, and he knows he has to introduce himself. Dr. Dalip Ragoobirsingh. I hope I got it right. Yeah. Ragoobirsingh.
I will help you.
You will help me.
Yeah.
I will have to learn a little Hindi or one of the languages of India and Trinidad, you may say, and Guyana to get it correct. But throughout the program, we will. And he's here to talk about obesity, and it is for the 7th lecture, distinguished lecture of Dr. Bernard Sorrento, Dr. Soso, who we all loved. We will be back afterward from our sponsors. My God.
I'm part of a tough, smart,
constantly evolving,
never too old to learn community of human beings.
proud of country,
Proudly Caribbean, global citizens.
with convenient access to over 400 learning programs
Delivered both online and face-to-face.
from the Caribbean's University of First Choice.
My mind,
My life.
my world of possibilities is wide open.
Call, click, or visit the UWI Open Campus.
So it is okay if I would refer to you simply as Dalip. We go way back to probably CXC and other things that you will reveal about me that Dominicans may not know. Please keep the other things very confidential, Dalip. But welcome to Dominica. Is that the first time you are in Dominica?
Yes, thank you, Mr. Wilson, for your kind invitation and warm welcome. It is indeed my first visit to Dominica. I've long wanted to come to Dominica because I've heard it's one of the most beautiful islands on God's earth, and I have proven that over the few days that I've been here. So yes, it is the first visit, and it certainly will not be the last. The next one will certainly include my wife, who herself loves nature, and I'm sure she would be very interested in visiting at a later date. Just to correct you, in terms of name, my name is Dalip Ragoobirsingh. I am the professor of medical biochemistry and diabetology. I'm a graduate of the University of the West Indies, the Faculty of Medical Sciences, where I completed a medical PhD with specialization in diabetes and its complications. And subsequent to that, I got a Rhodes Research Fellowship, which I took up in the Department of Medicine, University of Newcastle in the UK, where I was attached to the Human Diabetes and Metabolic Unit. And subsequent to that, I've been a visiting fellow at the Mayo Clinic in Minnesota, USA, visiting professor at the University of Pittsburgh, as well as visiting professor at the Miami School of Medicine. And more recently, I was a Fulbright scholar at the Pan American Health Organization headquarters in Washington, D.C., in the non-communicable diseases unit. So, it is really a privilege and pleasure for me to be here to give this distinguished lecture. I feel, very honored and humbled, because I know that Dr. Sorrento had a very illustrious career, and it was underpinned by you know, a strong spirituality. And of course, I know he had at his side, like me, a strong Jamaican wife. You know?
Yes. It seems that any doctor, well, that was the maxim before in Dominica, Dalip, that you would go to study medicine in Jamaica, and one of the things that you return with is a wife from Jamaica. Somehow, the Jamaican ladies, and I can see Alfia Sorrento smiling, knowing that she, like many others, pulled the trick out of the bag and secured some of our top scholars, particularly those doing medicine. And there are several of them in Dominica with Jamaican wives. I say that with a little reservation. My son is at Mona, or studied at Mona, did medicine there, and is presently working at the KPH. And you are almost sending a message to me that invariably he will be married to some Jamaican.
Not necessarily so, but I think
I'll just correct you.
I think the regional integration,
yes,
is important to us.
Yes.
Certainly the medical sciences.
Okay.
And we want to do our part to keep the region together.
Oh, okay.
And I'll leave it at that.
Well, my son again will not pardon me for this, but yes, he has a Jamaican girlfriend who he has had for a number of years. So he may be falling into the same stream. And incidentally, I should tell you, the link with Bernard Sorrento. Dr. Bernard Sorrento delivered my wife for this chap, Andre Wilson. And Dr. Sorrento, I think, went to his grave, still believing that. And Andre was named after him.
Okay.
Because his name was Bernard Andrew Sorrento. My son's name is Andre Bernard Wilson.
Okay.
Okay. So you see the link.
Yes.
And he was there, delivered all three of my kids. And Dr. Dr. Soso, as we familiarly call him. But you said it's your first time to Dominica, and the number of places he has worked and places he has traveled to, I guess he's equally fit in terms of what we are going to be talking about, obesity. Yes, the topic was chosen by us, and we sought for someone in the UWI family to deliver it. And we are so grateful for you to have come to our shores to talk about this. Where do we start on obesity? What is obesity, or what do we define as obese?
Okay, there are two diagnostic tools that is used to determine obesity. One is the body mass index. Mm-hmm. And this is where you take your weight in kilograms, measured in kilograms, and you divide it by a height squared, measured in meters. Mm-hmm. If you are less than 19 kilogram meters to the minus 2, then you're undernourished. And walking around in Dominica, I don't see very many undernourished people. Between 19.1, let's say, and 24.9 kilograms meters to the minus 2, then you are good weight for height. If you are from 25 to 29.9, then you are overweight, and over 30 is considered obese.
Obese.
You can also do waist measurements, and our waist is measured not like when you're making dress, where you put the dressmaker puts the tape around you, anywhere between the breast and the hip, and wherever looks smallest, they call it your waist. No. Clinically, your waist is between the midpoint between the lower rib margin and the hip bone, or the iliac crest.
Yes.
And it usually, across the front, coincides with the navel, and it runs parallel to the back. For women, it should be not greater than 80 centimeters or 32 inches.
32 inches.
For men, it must not be greater than 94 centimeters or 38 inches.
38.
So using one...
Immaterial of your height.
No, yes, regardless of your height.
Because the waist size should be, for women, not greater than 32
centimeters or 32 inches.
Inches, yes.
or 38 inches from it. I'm not sure, do you use
Well,
metric
metric has been around since the French embarked on it with the Système International.
Okay.
But we still use the British inches. People can translate that. For example, in sports, if I say someone has jumped 8 meters, people are still trying to comprehend what is 8 meters. They prefer to hear something like 25 feet.
Right.
Yes.
Okay. Yeah. So those are the two diagnostic criteria that is used commonly to define obesity.
So what I'd like you to do, again, Dalip, is to go over this, the body mass. Because some people out there with their calculators or computers going to compute and probably getting nervous, getting a tape measure and trying to follow what you have just said there, which is a good exercise. The body mass is, you say, the weight in kilograms?
Yes.
Not in pounds?
No.
In kilograms, yes.
Divided by height squared.
Height squared.
Measured in meters.
Yes. So, for example, if you are 5 feet, as many of the, I'm targeting women, and I'm not being sexist here, and I'll tell you why later, when we speak of complication and implications of obesity. If you are 5 feet, that squared is 5 times 5 is 25. So whatever your mass is in kilogram, divide it now by 20.
But it must be in meters.
In meters.
In meters.
Yes.
So it can't be in feet.
Feet. Oh,
it
yeah.
Be in meters.
Because we have wrong units here.
Yeah. So you have to divide by maybe
related to meters.
1.6.
1.6, yes.
Roughly. Yeah?
Squared. Yes.
Squared. Right.
Yeah.
And
so we got that?
Yeah. And
okay.
So normal weight for height will be between 19.1 and 24.9.
9.
If you go to 25 to 29.9 kilogram meters to the minus 2, which is the units in which it is measured, then you are overweight.
Yes, cause for concern.
Yes. And then, of course, when you get to 30 and above, then you are really in the danger zone.
Okay.
Really in the danger zone.
Okay.
So those are...
And then the factor of the waist measurement, you said.
The waist measurement,
girth.
yes. Because when you do the body mass index, you are really doing whole body.
Yes.
Obesity.
But
from our studies and in other international clinical trials, it has been shown that the waist measurement is a better predictor
indicator of obesity.
Of obesity and relates more positively with diabetes type 2.
As well as longevity. I've heard that. I don't know. In the research, you will tell us about it. That is, as I used to say, my dad had a very big girth. He died at an early age, but and I have friends, and most recently, about 2 years ago, one of my very young friends, because I am young also.
Yes.
Died, and he, I suspect, was obese because he had that tremendous waist or girth. Yeah. But as you said, the measurement is made between the lower rib
and the
hip bone.
And it's the midpoint.
Midpoint, yes.
All right, and usually it coincides at the front with where the navel is.
Yes.
And of course it runs parallel at the back.
So there you have it. And as we are told here, it is a better indicator of obesity than this body mass index.
And its relationship to type 2 diabetes.
Type 2 diabetes. Yeah. We will also then ask, what is diabetes? Because that too is one of the complications of obesity.
It is.
But we could go into that now to define, there are different types of diabetes.
Yes.
And let us hear from Dr. Dalip. You have to help me with the surname.
Ragoobirsingh.
Ragoobirsingh.
Yes.
Oh, yeah. I got it. Ragoobirsingh.
Simply put, diabetes is where you have a persistently high blood sugar. Persistently high. Because normally, if you eat a meal, over the next 2 hours, the blood sugar is high. But it should come down because in a normal person, the pancreas produces insulin, and insulin acts as a key on the target tissues for insulin, which includes the liver, skeletal muscle, and fat tissue. So it comes, it enters the lock that is on the surfaces of these target tissue and open it, and
to allow
the food from the blood to flow into the cells to be used.
And the food really, which I don't want to be too specific, but the food is usually glucose. That's what.
Well, it will be glucose, amino acids, proteins.
Yes.
It will also have fats.
Fats, yes.
Right, and electrolytes. So I'm glad that you raised that, because there is a misconception that insulin is responsible for the transport of only glucose. And I often emphasize to the young doctors that I teach that is a fallacy. It actually mediates the transport of breakdown products from proteins, fats, carbohydrates, and even electrolytes. So it's very important for you to note that.
Yes.
Now, that is in the normal subject. However, as you get increasing weight, as you become from overweight to obese, these locks on the cell surface of the target tissues become jammed. So insulin may come and bounce off, it cannot fit properly.
Yes.
So you have the inability of the food substances to move from the blood into the cell.
Okay.
So you actually have starvation in the midst of plenty. All right? So this is the classical clinical picture of the type 2 diabetic, which is 90% of the diabetes that we have. 9 out of every 10 diabetic has type 2 diabetes. And this is not only confined to the Caribbean, this is so internationally.
Okay.
This is so internationally. You have what is called insulin resistance, where the insulin is ineffective. You may be producing a lot of insulin. You may even have a condition known as hyperinsulinemia, high insulin in the blood.
Yes.
But it is not effective in turning that lock to allow the food to transfer from the blood into the cell. And that leads us to say that the symptoms, classical symptoms, now we can, understand. With the high sugar in the blood, the body tries to get rid of it. Yes. And so you tend to go to the bathroom regularly, tend to pass it out in the urine. So you have increased or frequent urination, all right, which is called polyuria by the clinicians. And because you are passing out a lot of water, you tend to be also very thirsty.
Dehydrated.
So you have what is called polydipsia. I've just said to you that diabetes really is starvation in the midst of plenty, because although you have a lot in the blood, a lot of food, it's not available to the cells. So the organs keep telling the brain, eat up, because we are hungry. We are starving. So you have increased appetite. And one of the other symptoms, classical symptoms, is that you tend to scratch a lot. You have an increase of itching. And infection, which is called pruritus.
And what happens to the blood? Is it becoming more viscous? Because there's all that...
Yeah, it tends to become and blood flow, which we'll talk about a little later in terms of discussing the complications.
Complications, okay.
All right. Now, you spoke about there being 2 types of diabetes, and there is. There is the type 1, which is the insulin-dependent diabetes mellitus. This is where the pancreas doesn't produce any insulin, and if it does, very little and very ineffective. So these patients have to be maintained on insulin injections every day, and sometimes more than once for the day. These patients tend to go into what is called ketoacidosis. A lot of patients who present in the accident and emergency in coma.
Yes.
Often you can smell on the breath this acetone, this nail polish breath coming off. And that's because there's an increase in the production of ketone bodies in the liver as a compensation for the sugar, which is not available for energy. These patients, at one time it was seen more in the young, and at one time it was called juvenile onset diabetes. But it is being seen in all age groups now and is described correctly as insulin-dependent diabetes mellitus, or type 1.
Type 1, yes. Okay.
All right? Now, there is the type 2, which I said before is 90% of the diabetics that you see in the clinic or in any survey
are type 2.
These can be managed on just lifestyle, diet and exercise, and other lifestyle changes. And when that is not as effective, you can introduce tablets or oral hypoglycemics. Let me point out that a number of these patients are asymptomatic. So the classical symptoms that I've described, they may not be showing it.
Yes.
In fact, a number of diabetics, type 2 diabetics, are discovered after the onset. So the time of diagnosis doesn't necessarily coincide with the time of onset. And as a result, they may even present with some of the complications, which I'll speak to in the later part of the program.
But there are other issues, although you have touched on them, but just for the listening and viewing public, you made mention of infantile diabetes. Juvenile, sorry, not infantile. But then there is maturity onset diabetes. For example, as we grow older, all of us inevitably become high blood pressure, as well as hyperglycemic, or in that maturity onset diabetes.
Right.
And there's also a diabetes that comes postpartum, is it after?
Well, it's gestational diabetes,
gestational
which is
diabetes.
seen. All right.
So can you just,
right,
also add this, that it doesn't deviate from type 2, but it is part of the whole gamut.
Yeah. I didn't want to get too technical.
I know, but people are aware of it.
Maturity onset diabetes, as you have said, is really maturity onset diabetes of the young, what they call MODY.
MODY, yes.
All right, so you're seeing it in the young adults. Gestational diabetes, you have to be careful in diagnosing it. You have to distinguish between a patient who is diabetic and becomes pregnant. As opposed to a patient who shows a diabetic tendency during pregnancy. The difference is gestational diabetes mellitus is diagnosed in the second trimester of a pregnancy. As you know, there are three trimesters. If you see hypoglycemia in the first trimester, it is likely that individual was a diabetic who became pregnant. I want to spend a little more time on this one because it is a little more perhaps relevant. And as we talk about obesity more, you would see why. The danger with gestational diabetes mellitus is that you need to treat it aggressively. And sometimes, if lifestyle changes are recommended, which it usually is, and is not efficacious in bringing the blood sugar within normal range, you may need to introduce small doses of insulin to keep the blood sugar tight. Why? Because if you neglect it, the fetus, when delivered, the baby will have enlarged organs, a condition known as macrosomia. So they'll born with a big brain,
big head, big
spleen, big liver. All right? So you want to ensure that you protect the fetus. At the same time, also allowing the mother, to have as normal a pregnancy as you can. So I'm happy that you raised that, if only to point that out. Now, type 2 diabetes, to go back to where we were, type 2 diabetes is the one that runs in family. It has a genetic component. And these usually either are obese or overweight on presentation or has a history of it. And this was often seen after age 40. So if you were fat and 40, you are a prime candidate. But now it is being seen even in the young. And that is why the World Health Organization accepted the recommendation to change the name to type 2, or what is called non-insulin dependent diabetes. Now these, as I said, can be managed effectively on a proper dietary regimen, exercises, along with other lifestyle changes, but may need to be put on oral hypoglycemics or tablets. And in the case of a stress, whether it's a pregnancy, an infection, or some kind of trauma, you may need to introduce small doses of insulin to achieve, normal blood sugar in the short term.
Yeah, is the treatment with insulin always invasive? Is it always by injection? I've heard of an insulin pump. Is that something that's incorporated?
In fact, it simulates the pancreas. There's an insertion, subdermally under the skin, and it is programmed to release insulin in pulsatile pulses. The reason why you can't take insulin by mouth is because insulin is a protein that will digest in the stomach. But it's always by way of injection. Insulin therapy is a very technical thing, and for the clinicians who are looking on, it would be important for you to have the oversight of an endocrinologist, one who is specialized in it, because there are a number of issues that you have to consider in administering insulin, whether it is twice a day, whether it is a split, whether it is long-acting with short-acting or just long-acting alone. There's a wide range of considerations in the management of type 1 diabetics. And the complications could be quite severe because the possibilities of fluctuation or spiking of the blood sugar in a type 1 diabetics perhaps is greater than in a type 2 diabetic.
Dalip, I know, well, that insulin is a very short, it's probably a polypeptide as opposed to a protein. Few amino acids make insulin. The synthetic insulin that we have to inject if we are diabetic, are there different grades or are there different efficacies of that insulin? So as to advise persons who are on insulin that sometimes they may not be getting either the correct doses or the good chemical ones that mimic the
Right. In the days when I was a student in 1930,
1930,
they used to use porcine insulin taken from the pig.
Yes.
And in some cases, beef insulin for people who had, religious reasons for not taking
the pig
pork insulin. Yes. Today, thankfully, with modern technology, a lot of the insulin that are produced are really done by DNA production. And so it mimics quite well the natural insulin.
Natural insulin. Okay.
The technical aspects of this really, in terms of insulin administration, has to do with the administration. You have to titrate carefully the dosages, and you want also to ensure that you have 24-hour coverage and that the patient knows how to store the insulin and how to manage the sites at which the insulin is administered, because it is a high risk for infection.
Yes.
And being diabetic alone makes you at risk
more
for infection.
prone to infection.
So if you don't manage the sites carefully, then you'd find that these sites will become infected, and right away you would need larger doses of insulin.
Yes.
Because the infections will cause a spiking of the blood sugar.
In the second half of the program, we will talk about complications of not only treatment, but what are the consequences of being obese and diabetic, conditions that emanate from it. But I'd like you to just address, because to be diabetic in the past was a social, there was uneasiness. That is, as if you were condemned, like AIDS now, to some extent. If you have AIDS now, or HIV, then you're an outcast, almost. Although that is changing slowly. But to be diabetic in the past, because it meant all the other complications you will talk about later. What is the position now? How do people globally view diabetics?
Well, the fact is, I was privileged to be in Kobe, Japan in 1994 when the International Diabetes Federation, in fact, I was invited by them to make a presentation.
You spoke Japanese then?
No, and I still don't. But at that meeting, they adopted diabetes education as an important modality in the management and prevention of diabetes. And with increasing diabetes education to both the patient, to healthcare providers, as well as policymakers, you find that there is a lot more ease. In fact, in schools, children who are diabetic, teachers need to know, and their peers need to know.
Yes.
Because they may recognize that the child might become hypoglycemic.
Which is more dangerous.
Which is dangerous and could die if not treated. So it is important that, that this information be given discreetly, and that the population be educated so that they do not discriminate against the diabetic or the person with diabetes, I would prefer call it, rather than a diabetic. Okay. So increasingly diabetes education is being disseminated.
And that has helped to dilute
tremendously.
The social rejection and all that.
And also helps a great deal with prevention as well as in the effective management of the diabetic.
So education forms a major part in the control.
Absolutely, and it's something I want to promote through this medium, and of course I would speak to it. And as I said, education is not confined to the patient only, and to healthcare professionals.
But also
support people and also policymakers.
Yes.
Policymakers, very important.
Let us take a break for sponsors. This should go on for 2 hours.
I'm part of a tough, smart,
Constantly evolving,
never too old to learn community of human beings.
proud of country,
Proudly Caribbean, global citizens.
with convenient access to over 400 learning programs
Delivered both online and face-to-face.
from the Caribbean's University of First Choice.
My mind,
My life.
my world of possibilities is wide open.
Call, click, or visit the UWI Open Campus.
So it has been a learning exercise for me. You listening and viewing, I hope it's also beneficial. And something churns in my stomach because I should tell you, Dr. Dalip has gone on and done tremendous work and continues to do so. I myself did biochemistry at the University of Surrey in England up to a master's level in clinical biochemistry. And some of the things are coming back. I love the correction on that insulin, as he says to all his students, and I being one now, that insulin is responsible for all the different breakdown products of fats, proteins, carbohydrates, etc., entering cells. And there it was, I had the concept that it was only glucose, because glucose is intimately related to diabetes.
That's right.
But anyway, and we would also talk about other hormones. He spoke about obesity, and I read somewhere, but I cannot recall the name, that is those persons who are prone to being obese in terms of family history. They have a particular short-chain polypeptide which triggers hunger, and then they continue to eat and eat and eat. But one thing I know, I believe in, and he will expound on that, is that you are what you eat. And as soon as you eat, that is stored, usually in the form of adipose tissue, fat. And more you eat is more you will store. Yes, exercise will help to tone, but I believe that with obesity, you should really control your eating. Some of us eat too much. In fact, it upsets me if I'm in a restaurant or anywhere and see something like, a tent, a mountain on a plate, as if there will be no food tomorrow. And people continually do this. And they wait until they get very obese for them to begin all sorts of regime of control, and even that is frustrating. Now, let us talk about the implication of being obese.
Okay, as you correctly pointed out, Felix, one of the cardinal reasons for obesity in the Caribbean is our overeating. Our eating habits, both in terms of the quantity and the quality, are of concern. We eat in excess. Our caloric intake is always in the excess of body requirement. And as you have said already correctly, that the excess is stored as fat. There are other reasons why someone can be obese. For example, you may have a hormonal problem. If you have something like low thyroid production, hypothyroidism, you'll find that the metabolic rate, or the rate at which the body deals with food, is reduced. So you find that you tend to put on weight. There are some of us who people say are born to be fat. And there is some truth. There's a genetic predisposition in some of us. If I take up this glass, I need to use energy to do that.
Yes.
There are some people who are able to burn energy even without touching the glass.
So they have high metabolic rate.
That's right. So it is what is called futile cycling. Now, in patients or subjects who have a high level of futile cycling, they tend to be slim.
Because I don't want to cut you, because your trend of thought, because there are some people who remain slim all their life.
That's right.
And they eat a lot.
That's true. And there are some people who drink water and they put on weight.
Yes.
And this is because of the decreased cycling. So they tend to put on weight. There are patients who may have pelvic surgery, who are what we call non-ambulatory, and they cannot exercise as often. You may introduce some physical therapy, but these tend to also become obese. All right. So there are other what you might call legitimate reasons for obesity, but by far greater numbers for, who become obese because of overeating.
Yes.
And as I've said before, it is not just the quantity but the quality.
But is there also a mindset why people eat a lot? Because
the thing is, I'm glad you raised that. I'm glad that you say that. We have some. We are our worst enemies.
Yes.
Because we have some traditions which I think facilitate obesity. For example, when I was growing up, to be fat seemed to suggest that you're healthy.
You're healthy.
Yes. And you
live in well.
You know for yourself that fat women are more attractive. Right? Fat women.
You would expect that.
And then they say that
if they have a nice bumper, whatever that means.
Well, yes. I'm not going to go that far in the anatomy. And also, it is said that it is a sign of prosperity. So we have to disabuse. In fact, I was just in London in July giving 3 seminars to the Caribbean diaspora. And some of our people who migrated years ago has passed down those traditions to their children, because some of them came with children to the seminars and they agreed that this has been their teaching.
You're
which
not
they
looking
hold tenaciously.
well.
But this is it, if you are slim.
Yeah.
So this is part of the tradition that engenders this kind of obesity. And let me say from the literature that 25% to 30% of the adult population across the Caribbean is obese. And I've just completed a study in collaboration with the Florida International University among adolescents. And we saw that in 10 schools in Jamaica, 33%, and the girls are in the ascendancy. Girls are more obese or overweight or obese. And these young students are already showing signs of chronic diseases and a predisposition to it. So it's a real problem. I want to add, just following on the discussion from the first part of the program, 8 to 14% across the Caribbean of adults, and adults here is 15 years and over, are diabetic, with an average of 11%. 9.3.4% are women. 6.4%, when you disaggregate the figures, are men. So our women seem to be in the ascendancy.
And usually, are we saying that the women are less active than
is that it could be
contributory
some
factor?
people feel that because of family responsibilities they cannot exercise as often. They're all the ones sometimes in the kitchen tasting, and by the time they finish cooking they have
eaten so much.
Among other reasons. The other thing too, in some of the Caribbean territories, crime rate has risen. So it's not so safe to go out and walk anymore late in the evening when they may have time. And crime here is not only murders but rapes. So you find that the females will be
confined to home, as well as the jobs that they do. That's sedentary, secretarial, and
which is on the increase. And in the adolescents, they are playing a lot more video games. When I was a boy in 1930, I used to be running around playing cricket, playing football however good or bad I did.
Hide and seek, everything.
That's right, which required consumption of energy.
Well, something I observed, which is related, at schools in the Caribbean, during break time, recess, you would see girls skipping, jumping, doing all sorts of things, throwing balls, catchers, or whatever it is. That doesn't happen anymore?
Not much more, no. There's a lot of technology now, people with their iPods, the computer games.
And secondary school students, by third form, the women do not get involved in sports. They do up their hair, their makeup, and they do not want to see any sweat.
In fact, as you say that, out of the study which I described to you in schools, we have had the government who provide a meal for students, looking now at the quality of these meals. And we are trying to mobilize, for them to introduce PE, physical education, beyond third form or on a ninth grade. And we are also trying to influence policy with respect to what is sold in schools.
Like the soft drinks.
High energy, sugary drinks, high energy, or energy dense snacks, and even, as I said before, the meals. In an effort to see whether we can change for the better, because this is the generation to come that will replace you and I in another few short years. you know.
If
so,
there will be a generation.
Well, you
to
know,
replace.
the way, well,
the
the way in
trend.
which this is it, and we are trying to arrest.
Yes.
And again, I want to compliment the organizers of this particular lecture. Not so much because they took the risk of inviting me, but the topic, I think, is timely. And I hope and pray that it will not only reach the public and the healthcare professionals, but surely the policy makers, because these are the movers and shakers of society. And with respect, they can make a lot of difference.
Well, Dalip, I humbly want to tell you that I'm smiling because I actually chose the topic.
Okay.
And I asked Dr. Francis Severin, who is our director of the OCCS, Open Campus and Country Sites, to find somebody for me, be it in Trinidad or at Mona, to talk about it, because I am very, very concerned about obesity. For example, you know Carnival in Trinidad. When I sit on the TV and I watch live, everybody look more slim and trim.
Around that time.
Around that time,
right.
okay? So they've exercised, they've dieted or whatever it is. But if you look at a Dominican band, you wonder what is happening. In fact, we used to have a competition. Now it has ended, and I'm so happy for that. Miss Big. And people were celebrating. I know all of us have to have a little bit of entertainment. But to promote a Miss Big, I mean, my God. That's my view. And I know I will be attacked for that.
No, I'm glad you raised
the Miss Large and Beautiful.
Well, this is
there was no beauty for me.
This is a trend that is now taking up. It's across the Caribbean, where they have what is called the fluffy diva, as if they are glorifying this overweight, you know, in our female counterparts, particularly, and that is unhealthy and ungodly.
Yes. So that leads me now to tease you on. Tell us about all the complications of being obese.
Okay. Well, we have spoken about type 2 diabetes already, and as I'm going to point out now that diabetes type 2 is a head-to-foot disease. Diabetes is the leading cause of blindness.
Yes.
Is the leading cause of heart disease, kidney failure, sexual impotence in male and female, as well as we lose more lower limbs in the Caribbean than any other part of the world.
So more amputees
are severe. I want to speak, however, to strokes, heart attacks, and high blood pressure as complications of obesity, which are also complications of diabetes type 2. Now, one of the common, what you call metabolic complications of obesity is that you have high blood fats. The fat levels or lipid levels in the blood tend to be above normal. And when it gets to a certain critical threshold, it begins to bruise the inner lining of the blood vessels of higher blood pressure, which include the blood vessels feeding the head, the carotid arteries, the coronaries feeding the heart, as well as those feeding the kidneys.
The arteries, for those who want to know, are those vessels, blood vessels that take blood away from the heart.
And to the organs.
Yes.
And what happens is that as this injury occurs in these vessels, you have other blood components like platelets, white blood cells, gravitating towards in an attempt to help heal.
The damage.
And these begin to be laid down as layers, and you have hardening of the arteries. So what happens is that as the arteries in the neck hardens, pieces break off, and will go to the brain, and you have what is called a non-hemorrhagic or non-bleeding stroke.
Yes.
If the same process is happening in the heart, the opening in the vessel that feeds the heart with fuel or oxygen and food becomes less, and so you have a reduction in food and fuel going to the heart, and after a while the heart dies, and you have a major heart attack. Same process occurring in the vessels feeding the kidneys causes changes. The kidney responds, and you have an increase in blood volume. You have also what is called generalized vasoconstriction. In other words, all the blood vessels begin to and that leads to high blood pressure. Now, high blood pressure also can cause heart attacks, because it's like when you go to the gym. When you are lifting weights, the muscle tend to get bigger. It is as if you have a persistent high blood pressure, it is as if the heart is bench pressing, and after a while begins to swell. And the vessels feeding it cannot continue to feed it indefinitely as it enlarges. And after a while, the heart will fail. So you have a heart attack by another mechanism. The same high blood pressure can rupture blood vessels.
So I think for the benefit of others, you spoke of stroke, which is very different from heart attack.
Yes.
So we just have to get that. A stroke is...
And then you have what we have described already as a non-bleeding stroke.
Non-bleeding
I'm now going to tell you that the high blood pressure can rupture blood vessels in the head. And you have what is called a bleeding stroke.
Is that in any way linked to aneurysms? Do you get aneurysms where the walls of the blood vessels get puffy like little balloons, and then that may rupture,
and you have bleeding. Okay, that's right.
So please differentiate between a stroke and a heart attack.
That's right, because the stroke has more to do with the brain function.
Brain function, yes.
And there are two types. There's the bleeding stroke and the non-bleeding stroke. And you have heart attacks from what is called blockage of the arteries or swelling of the heart. So one or two. All right. So these complications are outcomes of obesity. So when you look at obesity and you think it's just overweight, there's a lot of damage that is being done internally by diabetes as well as by this high fats in the blood.
And ultimately, I like that part because that to me is the most scary. Longevity. The lifespan is reduced.
Considerably. Mortality, which is what, and also morbidity. Your productive years are reduced. So your ability to work and function is greatly impaired and severely reduced. I want to use this medium to speak to a practice. We spoke about some of our traditions. A few years ago, I was serving as a technical advisor to the Pan American Health Organization in a 10 territories improvement in the quality of care of diabetes. And every territory, except with no exception, patients understood that diabetes could not be cured but controlled, but often were guilty of using bush tea. These bush remedies, either with their prescribed medication or instead of their prescribed medication. And that is, as one of our Jamaican DJs says, living dangerous.
Living dangerously. I know that song. Many young people can
will identify with that.
But I'm happy you have mentioned about the the traditional medicines and the bush tea, etc. And psychologically, people feel that is the best thing. They do not know about dosage.
Well,
there is no clinical studies of how it works. They take any amount, and the more they take, they figure psychosomatic. It's good for them. Well, tell us a little about it.
We have done some studies, some trials in the metabolic team that I worked on, and that's why we can speak with some authority on it. Some of them that I use do have potent active ingredients that will reduce blood sugar.
I would think so, yes.
But when you take it in the native state, there are other compounds that are harmful.
Yes. Either breakdown compounds. Or sometimes they may attach to other body things.
Exactly so. And what we have done, we have tried to isolate some of these in animal studies, and we fed it to animal models, dogs, which are perhaps the best model for the studies in diabetes. And what we found is that indeed there is some lowering of the blood sugar, whether it is masking the blood sugar or whether it is actually reducing it by
preventing
modalities that are known to us, mechanisms that we are known. We had, as part of that metabolic team, a vascular surgeon who used to biopsy major organs, and an anatomical pathologist who would do the histological studies. And they reported that there was evidence of severe damage to the liver by stacking of the mitochondria and cell debris, and severe damage to the kidneys and the spleen. A number of patients that were presenting at University Hospital saying that, they showed up with very high blood sugars, because I can tell you one professorial colleague of mine said, one of our patients, elderly patients, came to her and said, "Doc, I've been healed." So she said, "What do you mean?" She said, "I don't see any sugar my blood sugar seemed to be normal." About 3 days later, The doctor was called to the ward because she was promptly into a hypoglycemic coma. The bush tea was masking, so she was getting wrong readings.
Readings, yes.
And that was happening quite often over a period of time in Jamaica. And when I joined the metabolic team in the mid-80s, we did a retrospective study. We looked at patients who admitted to having taken bush teas as part of their
regime.
Yeah. And we compared them with patients, other diabetics who have diabetes of similar duration. We even tried to match gender in terms of male and female ratio, age of patient, but those patients were not taken. And do you know, when we look at the microalbuminuria, which is the excretion of microalbumin in the urine,
Yes.
those that...
I'm going to stop you there because
Okay.
let's take a word for the sponsors.
Okay, thank you.
I'm part of a tough, smart,
Constantly evolving,
never too old to learn community of human beings.
proud of country,
Proudly Caribbean, global citizens.
with convenient access to over 400 learning programs
Delivered both online and face-to-face.
from the Caribbean's University of First Choice.
My mind,
My life.
my world of possibilities is wide open.
Call, click, or visit the UWI Open Campus.
Yeah, Dalip, I am sorry I interrupted your trend of thought. We always have to remember a word for our sponsors and who else? The University of the West Indies. This is so interesting. In the next 10 or so minutes, I'm going to make you come home. That is, we have been speaking about bush tea, which is coming home, but particularly you would have been involved or be aware of Aki and glycine it is.
Hypoglycemia. Hypoglycemia.
Well, with hypoglycemic from Aki, which Jamaicans love, but if not prepared well, particularly in the young persons, can cause
Low blood sugar.
low blood hypo, and that is probably one of the most dangerous things. You go into a coma, etc. He will tell us more about it.
Yeah.
What Jamaica should be given accolade because they were entered in several medical journals or having done all the research work to show some of those deaths that were occurring in Jamaica a long time ago because of the love for ackee and saltfish. Okay, so tell us any further developments?
No, the thing is, in fact, I was contacted by colleagues at the University of California because they were interested in looking at the hypoglycin that is found in ackee. You are right.
Yes.
There was a time when, if ackee is not properly prepared, the hypoglycin remains, and if ingested in sufficient quantities, the patients would go into hypoglycemia, and you had what is called Jamaican vomiting sickness. A lot of people were presenting at A&E, accident and emergency, with this. And so you are well advised to boil the ackee properly so that you extract as much of the hypoglycin. There are people who have advocated that maybe it can be looked at as a possible oral therapy, and there may be some virtue in that. The thing is with these, one of the things that we are restricted by, certainly at the Mona campus, is the amount of grant funding you can get, because these things is millions of dollars and several years down the road
of research.
before it is before it can be actually put out on the market. So I believe that there are colleagues at the University of California who would like to partner with us and have been exploring those possibilities, and I think it will take a number of years and millions of US dollars down the road before we can actually produce some effective drug that can be used in the treatment and management of diabetes. I want to go back though, just to finish the point about the kidneys.
Yes.
And to say that in that study where patients who admitted to taking these bush teas and were showing high levels of microalbumin being excreted, they suffer more kidney failure. And in fact and in truth, one of my compatriots, Professor Barton, is currently spending a lot of time around Jamaica putting up dialysis, and it's costing quite a lot in management of patients. So that is, as much as I can say in terms of the effects and implications of using bush teas, and there may be others. So we have put out a strong warning, and I want to extend that warning to my fellow Dominicans who are looking on and listening that unless there is scientific proof or support which will enhance or endorse the use of a particular bush in the treatment of your diabetes or other disorders, I would suggest that you stay away.
Okay, but I will say to you, because many persons will be interested and want you to come back on such a program, because there are lots of bush doctors using, you may say, traditional medicine with no scientific proof, but then sometimes they go into journals and how they interpret, they say, look, they are doing exactly what we're saying, but in a different way. We don't have to go to university to do medicine, but from our experiences, and the experiences are handed down from their grandparents. Oh, my grandparent drank bush tea. You know, we can call a host of names because Dominica has a plethora of bush teas, and they will say to you, she lived 90 years, she lived 100 years.
I'm glad you raised that, because I would like to address that.
Yes.
Let me stick to what I know. Grandma and great-grandma who would have taken bush teas may not have been diabetic. And their immune system might have been able to detoxify the harmful substances and excrete it as innocuous substances by way of the urine.
Okay.
In the diabetic, the immune system is compromised. And these effective detoxifying mechanisms are also compromised. And that is why the diabetic will be more vulnerable. And I will leave it at that.
Okay.
I'll leave it at that. So I can,
I would also say,
I can only speak with authority
yes,
about the diabetics.
Yes, but I would also say in grandma time, there were less complicated chemical things that went into us than what is happening now.
Exactly.
You have all sorts of synthetic things that we cannot avoid.
No, your grandma had to walk miles.
Miles, yes.
Can I give you in the last
She was also involved in agriculture, etc.
Precisely point.
Yes.
Can I give you, I just want to make reference a story. There is a little island in the Pacific known as Nauru.
Nauru, yes.
Where
it's in the Commonwealth countries.
Right, where when a case of diabetes was presented at accident and emergency, it was a medical emergency.
Wow.
People used to gravitate to see what this thing looked like. Today, they are reputed to have the highest prevalence of diabetes. Why?
The diet has changed.
Precisely point.
Fantastic.
When the birds fly north for the winter, the droppings fell on Nauru and it became a rich phosphate deposit. Our North Americans friends moved in to mine it, and in came March Kernel along with some of the other beverages that you know well.
Yes.
And today,
change the lifestyle of the people.
Of course. And today, the king of Nauru needs to sit on a throne big like this because he is morbidly obese.
Oh, my.
And they have the highest prevalence
Of.
based on the last epidemiological study of the prevalence of diabetes in the world. So it gives you an example. In Grandma Day, she used to walk to the field miles. And she was not plagued, as you correctly say, by these environmental toxins and other things. Their eating habits would have been much better.
Simpler and yes.
Simpler. Lots of vegetables, little meat, if any.
Yes.
Moderate amount of carbohydrates, enough fruits. So comparing that era to this is like comparing chalk to cheese. And in some ways, they live better and healthier.
Yes.
Although we think we are it in this modern era.
Okay. No one would like me to have you leave this program that is organized by the University of West Indies Open Campus Dominica site without asking for some bit of advice. Yes, we have heard what diabetes is. We have also known some of the complications, and there are probably many more that we did not have a chance to talk about. But what in the closing moments, the last 2 minutes, some sort of advice that people want to live with, because okay, he has said a lot, he has put some fear in us, but we want some advice. How to proceed from now on? Is it too late? What can we do?
No, I think lifestyle changes is cardinal in the prevention and management of diabetes. And I want to explain that. Low caloric diet. Now, diet therapy is something that is individualized. So you would have to work with your dietitian, nutritionist, healthcare provider to give you something specific for you. But I would say broadly that a low caloric diet with good portions of vegetables, lean meat that is seasoned, I would add using natural seasoning like our Rasta friends, and should be baked steamed, grilled, or even barbecue. Leave the other preparations for special occasions.
Yes.
And you want to also get some of your starches from your staples. The ground provisions are perhaps the healthiest
Yes.
starches because they are high in fiber and they absorb.
Although we have to be mindful of the chemicals that are put in the ground to fight nematodes and other fungi.
That is also something that you have to consider.
Pesticides and so on. Yes, that you have to consider. But ground provision, much more than pasta.
Yeah. And also, of course, if you have a proper diet regimen, moderate exercises, walking 20 to 30 minutes, 3 to 5 days a week. You will also have to consult your healthcare provider because he or she will advise you based on your own clinical assessment. And of course, reduction in alcohol consumption, cessation of smoking of cigarettes and anything else that you smoke. Anything else that you smoke. All right, so cessation of that. Those are the lifestyle changes. And if those are not effective, then your physician or your attending healthcare professional may introduce some drug therapy to help. And in the case of the morbid obese patients, surgical procedures such as liposuction, gastric bypass, among others, can be utilized.
We will leave you with that advice, and please look forward to our next program on the third Thursday in the month of September. I think this was not only a learning exercise, an education in itself, and at the lecture, everything here would be reinforced today. Good night, and look forward to the next program. Thank you.
Yeah.
Fantastic.